discuss a case of a 75-year-old patient who presented with about a month history of severe back pain, intractable to pain medications. And she was found to, she had an MRI of the spine, and she was found to have multiple compression fractures in the lumbar spine. Further workup with the CBC shows that she was anemic with a hemoglobin of 10.5. The CMP show a normal calcium, a creatinine of 1.7. Other electrolytes were unremarkable. Further workup showed that she had a serum protein electrophoresis that was negative with no M spike, but serum-free light chains were elevated with a kappa about 1,000 and lambda 1 making the ratio 2,000. Because this was pretty suggestive of multiple myeloma, she had a bone marrow biopsy, and we showed 25% cellularity and 80% plasma cells. Cytogenetics were 46XX, and she did not have any abnormalities by FISH. She also had a bone survey that showed multiple lytic lesions in multiple bones and in her spine. Her beta-2 microglobulin, which was done for staging, was 4.7, and she had an albumin of 3.9. So, in summary, this is a 75-year-old female patient recently diagnosed with multiple myeloma. She would be Dury-Salmon stage 3A, and she would be International Staging System 2. The patient clearly needed treatment since she had, myeloma bone disease and was also anemic, and she was started on Velcade, Revlimid, and dexamethasone and daratumumab. In summary, this is a 75-year-old female patient with recently diagnosed Dury-Salmon stage 3A, ISS2, multiple myeloma. The patient did not have any comorbidities, so she clearly needed treatment, and initially she was thought to be a transplant candidate due to her performance status. And she was started on Velcade, Revlimid, dexamethasone, and daratumumab. The selection of this treatment was probably based on recent data showing that combination of 4 drugs is a very appropriate and very effective combination for transplant-eligible patients based on a recent study, the Griffin study. The criteria that we would use to define if a patient is transplant-eligible is usually more physiological age rather than chronological age. That's probably the number one point. Here, we really evaluate all the patients as potential transplant candidates and evaluate their past medical history, their performance status, their comorbidities, and then make a decision based on that. So it's a minority of the patients because myeloma, the median age of diagnosis is 70, so the majority of the patients are older, have multiple comorbidities. So it's a small percent of patients that are actually true transplant candidates, and also even a smaller percent that actually have access to transplant. The role of transplant in myeloma is still very important, despite the fact that we have newer therapies for induction that increase the rates of complete remission. Most studies that have looked at those therapies look at induction for a few cycles, followed by transplant consolidation, followed by maintenance therapy. And we really get that deep responses after transplant consolidation and into maintenance. So transplant still remains very important in myeloma, and I think further studies would have to be done comparing these 4 drug combinations to a transplant arm to really see if that would make a difference if you keep the patients on this drug for a long time. A different question would be patients, for example, that are able to achieve a stringent complete remission with the induction, let's say with 4 cycles of Revlimid, Velcade, dexamethasone, and daratumumab. However, that's a minority of the patients.